This is basically what do we know, what do we not know talk. So we're going to briefly talk about the history of impaired glucose tolerance and indeterminate glycemia. And then we're going to basically touch on the outcomes associated with both. The history is somewhat relevant because it kind of sets the stage as to what barriers we ran into in the past and what barriers we're running into today. So, and then we'll briefly touch on the literature for treatment. It's very sparse. And then we'll talk about where we need to go. So a little bit about history. So this is from one of the first papers that described impaired glucose tolerance in cystic fibrosis. You can see it says the glucose intolerance in these patients appears to be characterized by absent or sluggish response to oral glucose administration. Kind of shows you where we're at today. We know a lot more, but we're kind of still here. So comparing the history of oral glucose tolerance testing to type 2 diabetes is extremely relevant, and it kind of gives you an idea what the timeline is for cystic fibrosis as well. So in the 50s, impaired glucose tolerance was noted in pregnant women, and more importantly, they were associated with complications such as macrosomia. By the 60s, it became oral glucose tolerance testing became more recognizable, and people were basically requesting standardization to improve research and whatnot. And then by the 70s in type 2 diabetes, we started to see the outcomes surrounding retinopathy and whatnot. So there's a huge asterisk associated to that, and we'll talk about that shortly, in that the clinical significance of glucose tolerance testing was debated all throughout time, and that kind of led to a delay in its use. And this is the case for cystic fibrosis as well. So in 1969, the same paper I cited before described impaired glucose tolerance testing. By the 80s, 90s, we started to see these large CF centers, and then later in the 2000s, we got our guidelines for cystic fibrosis. And we kind of faced those same barriers with type 2 diabetes. So this is actually from an earlier paper for type 2 diabetes, kind of outlining the debate about clinical significance, noting that we know that glucose tolerance testing has a role, we just don't know what to do with it. So characterization of glucose tolerance, I'm not going to go into this a lot because my Dr. Kahari did a great job doing that. So these are all the classifications. We're talking about indeterminate glucose tolerance and impaired glucose tolerance. More importantly, I want you to think about the mental framework that you have surrounding these classifications, and actually Dr. Moran alluded to this earlier today in her comment, in that even though we have these classifications, it's more of a spectrum, and really we need to wrap our head around the fact that knowing where they're at in terms of this spectrum gives us an idea as far as how sick they could potentially be. And once you fall into the diabetes category, you definitely know the risk of mortality, the risk of complications, but as you kind of go towards that impaired glucose tolerance, that indeterminate glycemia part, you know that there's a risk, but probably not to the same degree. So the relevance of glucose tolerance testing to CFRD surrounds the physiology. It goes back to the first and second phase insulin secretion. And it's this natural progression where you have this loss of first phase insulin secretion, which is at peak, and then eventually over time you have that loss of the second phase insulin secretion. And we actually knew that early on. So from that same 1969 paper I cited already, you can actually see that. So they broke them up into different glucose tolerance categories, and you can actually see that loss of first and second phase insulin secretion. So let's talk about outcomes. So for impaired glucose tolerance, the first set of outcomes that were kind of described were primarily surrounding lung function. So Lang et al. In the early 90s did a couple cross-sectional studies looking at the temporal progression of basically diabetes onset. They actually looked at pre-diabetes as well, and they basically looked at lung function and weight, and they showed that basically impaired glucose tolerance in CFRD showed a decrease in FEV1 and forced vital capacity. They also showed basically clinical deterioration by NIH scoring. And they also showed that people at pre-diabetes basically showed decrease in lung function before onset of diabetes. Tofi et al. Did another cross-sectional study showing something similar. And then Costa did another cross-sectional study, except they looked at non-traditional metrics, and they also compared that to the classic glucose tolerance categories. So they looked at area under the curve, they broke them up into quartiles, and they basically showed that doing that might actually be a better predictor of outcomes for impaired glucose tolerance than just saying they have, impaired glucose tolerance or, CFRD. So I have the data from all of these studies. I'm just going to briefly touch on them. The point is just to put them here for you guys if you need to reference them. But this is the data from Lang. Basically, you can actually see in the middle of the table that there is a decrease in FEV1 and FVC. The other important thing that we kind of learned from the study is how hemoglobin A1C is not that useful. So this is one of the earlier studies that basically showed that, OGTT diagnoses diabetes, but most of the people that had an OGTT with diabetes actually had an A1C of 5.9%. So their second study, they showed how pre-diabetics eventually had a deterioration in lung function. And then in Tofi's article, you can see the decline in FEV1 and FVC based on the tolerance classifications. White's FEV1, black is FVC. And then Costa's group, this is their breakdown as far as looking at area under the curve. And the lowest and highest quartiles basically showing the drastic difference in FEV1 and FVC. For weight, it's actually same authors for the most part. And very similar data in that Lang basically showed that pre-diabetics saw a decrease in BMI and weight. It was not as significant as past studies, but Tofi et al. Basically showed that there's a negative linear correlation between the 2-hour blood glucose and BMI, and then Costa's group didn't actually show a difference. So this is the data showing weight decline in pre-diabetics. In Tofi's group, they looked at the different classifications as well. It's important to highlight that they actually didn't see a difference between impaired glucose tolerance and CFRD, and that was the case for lung function as well. As far as mortality, there's actually no data on impaired glucose tolerance strictly. Really the two main studies surrounding mortality surround CFRD. There's a retrospective cohort study that looked at 8,000 subjects in the UK that basically showed a higher risk. And then Dr. Blackman's group actually did the most recent study looking at basically mortality risk progression over time. And neither of those studies was there a breakdown in terms of glucose tolerance. So as far as INDET goes, or indeterminate glucose tolerance, this first originated from the diabetes prevention trial. And within this study, basically, they realized that a 1-hour glucose that's a little abnormal predicts type 1 diabetes, and that's why we use it in TrialNet. So since then, we've been leveraging this finding in type 1 diabetes, and we've applied it to cystic fibrosis, and that's kind of where it emerged. And this is actually one of the first tables or papers describing INDET in type 1 diabetes, actually from the diabetes prevention trial. So what do we know about INDET? So the takeaway is we don't know a lot. We are having suspicions about whether the cutoffs for INDET are appropriate or not. So a lot of our mentors here actually had a contribution to these. But Dr. Odie's group basically showed abnormal glucose tolerance in young kids, increased the risk of developing diabetes significantly. They did not break the group down into Indet specifically, though. So, Indet is within that abnormal glucose tolerance category. But they did not see a difference in lung function or weight. Schmidt's group basically found a difference between impaired fasting glucose, impaired glucose tolerance, Indet. They all predicted CFRD. Shaik's group basically showed that a lower cutoff than the traditional cutoff for Indet might predict CFRD, and they didn't see an association with lung function or weight. And then Dr. Kelly's group actually looked at a lower threshold, and they actually did physiologic studies on beta cell secretion and found that on thresholds that are below the classical Indet cutoff, you actually see beta cell function decrease. And then Piona's group basically showed similarly that at a lower cutoff, you can actually see different mechanistic differences and abnormalities than what we traditionally thought. And we'll talk a little bit about that when I get to their slide. So again, this is the difference. This is in Dr. Odie's group, where they basically saw no difference as far as weight and lung function in children who have abnormal glucose tolerance, so not particularly Indet. And then this is Schmidt's group basically showing Indet associated with CFRD progression. And then this is Dr. Kelly's data. It's a little busy, but really the takeaway is that the purple line is the early glucose intolerance, and you can see that insulin secretion in that, which is sorry, I can't point. It's actually on the far upper right-hand corner, is actually lower than the green line, which is a normal glucose tolerance. So you can see that there's an abnormality even at a much lower threshold than traditionally thought for Indet. And then Piona's group basically did oral glucose tolerance testing on patients, and they used mathematical modeling to basically characterize the determinants of glucose derangement in CF, and they basically have beta cell function, and then derivative controls basically phase 1, insulin secretion, proportional controls basically phase 2, and then insulin sensitivity and insulin clearance. And the natural progression is that you would expect that things would worsen from normal glucose tolerance all the way up to CFRD, but what they found is it's actually not in that sequential order. So for example, in Indet, and you can see that the derivative control is more prominent than actually impaired glucose tolerance. So this natural progression that we initially saw might not really be the case. So treatment with abnormal glucose tolerance, not a lot of data. 2 groups basically studied long-acting insulin and basically showed that there might be improvement in terms of FEV1 and weight. However, small studies, number 1 and number 2, no control group. And then Dr. Moran actually did a study looking at mealtime insulin and looked at BMI, and she didn't really see a difference. Really where we're at right now is we don't know what the cutoffs are for what would be the most appropriate cutoff for Indet. So there's there's data to basically suggest that the cutoff that we're using may not be sufficient, or there might need to be a new restructuring of the characterization. And another gap is what's the role of CGM? So can we leverage CGM to basically give us insight on glucose tolerance? And then really the other gap, and I know we've mentioned this like 8 times already, is the modulators. So with modulator therapy, will our CF-related outcomes change and thus impact how we screen, and will that ultimately impact how we characterize dysglycemia? So, thanks.